The first being the transverse ligament instability test, the second the alar ligament instability test. So if I can have a volunteer to have a seat up here, we'll start with the transverse ligament instability test. Great, thanks. Yes, and if you could face this way. Excellent. So for this test, we can begin, it's probably easiest to begin by contacting the C2 spinous process. So first we'll find that. We can begin at the skull, palpating inferiorly in the midline until we find that first posterior midline prominence, the C2 spinous process. From here, we're going to take a pinch grip contact, thumb and forefinger on either side of the C2 spinous to hold it in place. So looking kind of like that, pinched onto C2. So we'll find that, take our contact. Next from here, the patient is instructed simply to flex forward in their upper cervical spine. So you can say, with your upper neck, just bend forward and let your head rest there. Good. From here, we check in with our patient to see if this provokes the onset of neurological symptoms. So we could have radiating pain, paresthesia, and numbness. We could have visual changes, dizziness. Any of these can be associated with an upper cervical instability syndrome, wherein the posterior arch of C1 is now actually contacting the spinal cord. So this is a mass effect, kind of a compressive type of lesion. So the way we can confirm that that's present is if our patient does have symptoms here, then we can offer compression posteriorly from the forehead. So we're pushing at the forehead posteriorly, and this is going to have the effect of translating the head posteriorly on C1. So that's going to reposition the head if it is in fact sliding inappropriately forward, as well as C1, due to that transverse ligament being unstable, being damaged, being inappropriately lax. So what we're looking for here is the resolution or decrease of those symptoms provoked by flexion with this posterior pressure at the forehead. So now that we've repositioned the head in C1 on C2, are we seeing now a decrease in those symptoms? Additionally, do we have a sense of inappropriate translation? Is there a whole lot of movement there, or is there a soft or empty end feel to the movement, indicating that there's not a firm ligamentous barrier that's keeping those bony structures from moving excessively in one or more directions? So that's what we're looking for. This is a transverse ligament instability test. Questions?
So by placing our hand on the forehead, are we moving the head, do we tilt the head, or we try to move it like such?
The second one, and that's translation. So we're not trying to extend, this is a good question, we're not trying to extend the head and C1 over C2. Instead, we're trying to push the head and C1 posteriorly in translation. So if here's C1, here's C2, we're looking to do this movement rather than this movement extension.
Thank you.
Yeah. Any other questions?
So you said it's the transverse atlantal constructionist.
Exactly. Yes.
And are you bending your index finger, or are you this?
Yes, I like to have it bent simply to minimize, if possible, the amount of discomfort that this generates, kind of pinching C2 firmly. And it does have to be a pretty firm contact, so again, we want to be gentle but still do enough to get the work done. Yeah. Good. Any other questions for this one? Okay. Well, let's partner up and practice this, a relatively simple maneuver, but again,